Hi, my name is Lauren Fernback, and I'm here with Shabria Lanier. We're P4 students here at the College of Pharmacy, and we're doing a PowerPoint presentation on deep vein thrombosis treatment. Here are some statistics you should know about VTE. About 50% of blood clots are healthcare associated, including hospitalizations or surgery. And 70% of healthcare associated blood clots are preventable, but fewer than 50% of hospital patients receive the appropriate preventative treatment for these clots. What is VTE? VTE stands for venous thromboembolism. VTE includes deep vein thrombosis, or DVT, often found in the veins of the legs, thighs, or pelvis area. Pulmonary embolism, or PE, is found inside the lungs' arteries and blocks some or all of the blood supply to the lungs. To reiterate, deep vein thrombosis, or DVT, is a condition where a clot forms deep in the veins. Most common sites for DVT are lower legs and thighs. And then an embolism is a clot in the veins that break off and begin to travel through the bloodstream. This is what causes a PE, or pulmonary embolism. The next slide is about the incidence of VTE in the United States. About 900,000 people are affected by a DVT or PE in the United States each year. 1/3 of the people with a DVT or PE will have a recurrent episode within the next 10 years. Incidence rates for individuals greater than the age of 45 are higher in men. Below, you can see a chart. As you get older, the incidence rates are higher in men than they are in women. What causes VTE? In the diagram below, or Virchow's triad, this summarizes the mechanism by which acquired and inherited risk factors predispose to a VTE. Circulatory stasis is one part of the triad. AFib and left ventricular dysfunction can cause blood to pool in the upper chambers. When this blood is stagnant for too long, this is how a clot is formed. The clot is then pumped out of the heart and can lead to the lungs. Hypercoagulable state and vascular wall injury are also parts of the triad. Trauma or surgery, heart valve disease or replacement, indwelling catheters, malignancy, pregnancy, or sepsis all give a patient a higher risk at developing a clot. This slide discusses who is at risk for VTE. Some people have genetic abnormalities within their blood that causes their blood to clot, having cancer, smoking, women taking birth control pills or even having a baby, staying in the hospital or having surgery, or not moving for a while. All of these increase your risk for developing a VTE. Why do we assess for VTE? There's a clinical tool that is used to determine if a patient is at risk for VTE. This is called the Wells score. A patient's score will then give insight to their level of risk for the VTE. There's a 3-tier model and a 2-tier model for the Wells score that doctors use. On the next slide, we will show an example of a 3-tier model of the Wells score. The low, intermediate, and high risk assessment allows the clinician to provide appropriate prevention measures for each patient. It's imperative to decrease the probability of a VTE. On this slide, we have an example of the Wells score model. If patients have had active cancer, have paralysis, have been bedridden for longer than 3 days, or have had a major surgery within the last 4 weeks, have any signs or symptoms of DVT, these are all scored. This score reflects the risk of developing a DVT. It can be high, intermediate, or low risk. This helps the doctor decide whether to proceed with further diagnostic testing. The same thing can be done for pulmonary embolism. However, these questions are a little different from the one on the DVT slide. It looks for things such as clinical signs and symptoms of deep vein thrombosis, which is 3 points, heart rate greater than 100 beats per minute, 1.5 points, previous pulmonary embolism or DVT, 1.5 points, recent surgery, which is 1.5 points, and then cancer, which is 1 point. These are then added up and given the probability of a high, intermediate, or low risk for developing a DVT. Symptoms for DVT, or deep vein thrombosis, include swelling, pain, warmth in the lower limbs. Diagnostic tests include venography, elevated D-dimer, and an ultrasound. Clinical presentation of a pulmonary embolism includes symptoms of cough, chest pain, shortness of breath, and confusion. Pulmonary angiography, elevated D-dimer, and CT scan can also be diagnostic criteria for a pulmonary embolism. In this slide, we'll talk about how a clot is formed. The formation of a clot involves activation of a sequence of blood clotting factors that generate thrombin. Thrombin converts fibrinogen into long strands of fibrin that then help the platelets in the red blood cells stick together. The fibrin strands add bulk to the developing clot and help hold it in place to keep the vessel wall plugged. This slide shows the clotting cascade, with the intrinsic pathway on the left and the extrinsic pathway on the right. The intrinsic pathway is activated by damage directly done to the blood vessel and the exposure of collagen to the circulating platelets within the blood. The extrinsic pathway is activated by many things, including damage directly to the blood vessel, tissue damage outside of the blood vessel, sepsis, malignancy, and inflammation. Both the intrinsic and extrinsic pathways lead to factor 10, which is the start of the common pathway. These two key players of the common pathway are thrombin and fibrin. Fibrin is the most important part of the clotting cascade because fibrin then traps the platelets, therefore the clotting factor number 1. Thrombin is the second most important part of the clotting cascade because it activates just about everything, therefore this is called the clotting factor number 2. In simpler terms, the clotting factors lead to the common pathway, which then in turn goes to thrombin. Prothrombin activates thrombin, which then activates fibrinogen. Fibrinogen activates the fibrin clot, and that's how a clot is formed. There are many types of therapies that can be used for DVT treatment, such as heparin, low molecular weight heparins, factor 10A inhibitors, direct thrombin inhibitors, and vitamin K antagonists. Now we're going to talk about the anticoagulation therapy. These are the injectable agents. Unfractionated heparin, low molecular weight heparins, including enoxaparin and dalteparin, factor 10A inhibitors, which include fondaparinux, and direct thrombin inhibitors, which contains argatroban. First, we'll talk about unfractionated heparin. This drug binds to antithrombin, which inactivates thrombin factor 2A and factor 10A. Unfractionated heparin is preferred for renal insufficiency. These patients have a creatinine clearance that is less than 30 milliliters per minute. When using unfractionated heparin, some patients are at an increased risk for heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia, or HIT, is where the immune system forms antibodies to heparin, which leads to platelet activation. Patients should look for signs and symptoms of HIT: pain, redness, swelling of the arm or leg, bruise-like discoloration of the skin, weakness, numbness, or problems moving your arms or legs. There is also an unexplained decrease in platelet count by 50%. When using unfractionated heparin, there are monitoring parameters. You need to monitor your partial thromboplastin time after 6 hours from starting the medication. Then, every 6 hours until therapeutic range is reached, which is 1.5 to 2.5, and then every 24 hours. The prophylaxis dose for VTE when using unfractionated heparin is 5,000 units sub-Q every 8 to 12 hours. Treatment of VTE is 80 units per kilogram IV bolus followed by 18 units per kilogram per hour for the infusion. There's a fixed dose of 5,000 units IV bolus and then 1,000 units per hour for an IV infusion. The reversal agent for unfractionated heparin is proteamine sulfate. On this slide, it shows the initial loading dose of 80 to 100 units per kilogram with a maximum of 10,000 units, and an initial infusion rate of 17 to 20 units per kilogram per hour with a maximum of 2,300 units per hour. The infusions are adjusted based on the patient's activated partial prothromboplastin time. Below in the table is a weight-based unfractionated heparin administration by continuous infusion. On the left are the activated partial thromboplastin times, and then the adjustments are on the right.
Low molecular weight heparins bind to antithrombin, or AT, and have a higher affinity for inhibiting factor 10A more than factor 2A. It's recommended for initial and long-term treatment during pregnancy and is usually continued for at least 6 weeks after the delivery. And the two low molecular weight heparins are enoxaparin or Lovenox, dalteparin or Fragmin, and it may cause injection site reactions or bruising because they are injectables. This shows the prophylaxis dosing of the low molecular weight heparins. They are indicated for hip and knee replacement surgery, abdominal surgery, or just acute medical illness. And with that is only Lovenox that is usually given in the hospital, and it's based on weight. Here is the DVT treatment dosing. For enoxaparin or Lovenox, it's 1 milligram per kilogram sub-Q every 2 hours, or 1.5 milligrams per kilogram sub-Q every 24 hours. And if the patient has renal insufficiency with the creatinine clearance less than 30, then you would reduce their dose to 1 milligram per kilogram sub-Q every 24 hours. For dalteparin or Fragmin, it's usually used for patients who have cancer, and remember that the total daily dose should not exceed 18,000 units. And low molecular weight heparins are preferred due to their low number of side effects and much less monitoring parameters compared to the other agents. There is only one injectable factor 10A inhibitor, and that's fondaparinux or Rixtra, and it acts indirectly on factor 10A. It's used for prophylaxis and treatment of VTE. For prophylaxis, if you weigh more than 50 kilograms, then it would be 2.5 milligrams sub-Q daily. If you weigh less than 50 kilograms, then it is contraindicated. For the treatment of VTE, if you weigh less than 50 kilograms, it would only be 5 milligrams sub-Q daily. Between 50 and 100 kilograms, 7.5 milligrams sub-Q daily. And greater than 100 kilograms, it would be 10 milligrams sub-Q daily. For renal insufficiency with creatinine clearances less than 30 milliliters per minute, fondaparinux is contraindicated. There is also only one direct thrombin inhibitor that is injectable, and that's argatroban or Acova. And it's indicated for patients with heparin-induced thrombocytopenia and in patients who are undergoing PCI who are at risk for heparin-induced thrombocytopenia. And the initial dose is 2 micrograms per kilogram per minute. You would titrate it to your target activated partial thromboplastin time, or APTT, and the max dose will be 10 micrograms per kilogram per minute. Also be aware that this drug can increase INR. Now we can move on to the oral agents that are used for anticoagulation therapy. They include direct thrombin inhibitor, dabigatran or Pradaxa, factor 10A inhibitors including apixaban, betrixaban, edoxaban, and rivaroxaban, and then also the vitamin K antagonist known as warfarin. These are very important because these are the only oral agents that can be used for anticoagulation, and patients would rather be sent home on oral therapy or managed long term with oral therapy rather than injectable therapy. There is only one direct thrombin inhibitor that is available orally, and that's dabigatran or Pradaxa, and it directly inhibits the factor 2A by binding to the active site of free and clot-associated thrombin. And one of the major side effects with Pradaxa is significant heartburn or dyspepsia slash gastritis. And so the patient will kind of feel like their stomach is just burning, as you can see from the picture. And Pradaxa is unique because it has a specific reversal agent, adarucizumab or Praxpine, and it is a monoclonal antibody fragment, and it can be used to reverse Pradaxa. Factor 10A inhibitors, and they're called that because they're very potent and specifically selective for factor 10A. They include rivaroxaban or Xarelto, apixaban, which is Eliquis, edoxaban, which is Savaysa, betrixaban, which is Bavixa. This shows the dosing for both the direct thrombin inhibitor as well as the other factor 10A inhibitors. And as you can see, Pradaxa is not indicated for any type of prophylaxis of VTE, only acute VTE and extended VTE, as the other agents are mostly approved for treating and prophylaxis of VTE, with the exception of edoxaban. Vitamin K antagonist. This is the one and only warfarin, also known as Coumadin, also known as Jantoven, and it's most commonly used for long-term VTE management. It is an antagonist of vitamin K in the body, and vitamin K is a precursor to the clotting factors in the body, along with protein C and protein S. And as you can see from the picture below, warfarin comes in a lot of different colors, and it comes in many different doses depending on what the patient needs. When you think of warfarin, always think of INR. INR is the International Normalized Ratio, and this is used to monitor the level of warfarin in the body. Warfarin has a very narrow therapeutic index, and it's very important to stay within this index. And the way we stay within that index is by using the INR. So with the prothrombin time in the body, that is going to tell us how quickly the blood is clotting. However, it depends on what time zone you're in and where you are in the world. However, with the INR, the International Normalization Ratio, it will standardize the time between the laboratories. So if you're in Tallahassee or if you're in California, your INR will be the same. So, what type of INR are we looking for? What's a good INR? What's a bad INR? This picture right here pretty much sums it up very easily. Your target INR for most people is going to be between 2 and 3. The exception out of that range is for people who have mechanical heart valves. Their goal is going to be a little bit higher at 2.5 to 3.5. The higher your INR gets, the more likely you are to bleed. The lower your INR is, the more likely the person is to have clotting. So, it's very important to keep that balance right there in the middle in between bleeding and clotting. Okay, after we can grasp the concept of INR, now we can look at the major drug-drug interactions with warfarin that will in turn affect your INR level. So the top part of the table shows substances that may increase your INR and thereby increase your risk of bleeding. The lower part of the chart shows substances that may decrease your INR and your risk for clotting or thromboembolisms. These interact with warfarin and change the level of warfarin aside from the level that was prescribed. So it is very important to talk with your patients who are on warfarin about some of these potential interactions. This next table shows a list of foods and their level of vitamin K. Now, the level of vitamin K, the higher the level of vitamin K you get, the more warfarin you're going to need to maintain your specific INR. So if you're taking X amount of warfarin and you intake more vitamin K that day than usual, then you would need more warfarin to cover those foods or that level of vitamin K in your body. Therefore, foods with a high content in vitamin K will decrease your INR. You may have a patient that says, well, I've been taking my warfarin every day just like I'm supposed to, and I don't understand why my INR isn't at the level that it should be. Your next thought should be, well, what are you eating? What do you normally eat? And then, have you had any collard greens this week? Oh, yes. Last week, I just started eating collard greens every single day. There you go. That is what is affecting and decreasing their INR. So how do we make sure that our patients aren't eating too much vitamin K that's going to interact with their warfarin? We don't. We just make sure they maintain a consistent level of the vitamin K rich foods. So if you eat one whole plate of kale every single morning, make sure they continue to have that plate of kale every morning so we don't have to make adjustments to their warfarin in order to maintain the target INR. Injectable anticoagulation should overlap with the warfarin therapy for at least 5 days. This is how long it takes for the body, the levels of warfarin to be maintained in the body. And we also want to monitor if their INR is reaching the target. For most patients, the initial dose is 5 to 10 milligrams and then adjusted to maintain that target INR. This is a chart that shows how warfarin can be adjusted. So it's based on whether or not an INR can be obtained daily. If so, then it shows you how to proceed, what type of dose adjustments may need to be made. If not, then it shows how a little bit longer days, so you see it progress all the way to days 14 and see how dose adjustments are made. Many locations will have a Coumadin clinic or warfarin clinic that can monitor patients, and many patients go in for INRs weekly, but when initiating warfarin, it's important that patients are monitored very frequently to get them to their target dose. Warfarin is a very high risk drug. Luckily, there are agents to reverse warfarin. These agents include fresh frozen plasma, which is frozen blood plasma. There's Kcentra, which is prothrombin concentrates, and both Kcentra and fresh frozen plasma contain clotting factors that may have been lost by warfarin. Then it can also be reversed with vitamin K or phytonadione, which is also known as mephyton. Overall, for VTE treatment, patients who have proximal DVT should be on anticoagulation therapy for at least 3 months. And if a patient doesn't have any contraindications to oral therapy, then that should be first line for those patients. Oral therapies are also preferred in proximal DVT patients without cancer, and cancer patients should be treated with the low molecular weight heparins initially, and then followed by a long-term oral therapy. VTE can also be prevented by non-pharmacological treatment such as ambulation, which is a fancy word for walking. As you can see, the patient on the left is walking around in the hospital, which is excellent. Compression stockings, which look like socks that go on the lower leg. And then there's also IPC devices, or intermittent pneumatic compression devices, that are often used in the hospital, and they're shown on the right. And they just go over the lower leg and they compress the leg electronically. This is the end of our presentation. Here are our references. Thank you for watching.